Hello and welcome. On behalf of CME Outfitters, I'd like to welcome and thank you for joining us for Bridging Cultures, Foundations for Serving Latine Patients in Pharmacy Settings. Today, we're building the bridge. In this first foundational program and in parts 2 and 3, we'll delve into Spanish essentials and cultural awareness in action. This CMEO snack series is supported by an educational grant from CVS Health. I'm Dr. Jasmine Gonzalvo, and I have practiced clinically for about 20 years in a federally qualified health center, caring for primarily Spanish-speaking patients. I've also been faculty in the College of Pharmacy at Purdue University for about 20 years, and also serve as the director of the Center for Health Excellence, Quality, and Innovation through Purdue. I'm joined today by my distinguished colleague, Dr. Maria Hearns Rivas. Can you introduce yourself?
Thank you so much, Dr. Gonzalo. It's a great pleasure to be here with you all. Yes, my name's Dr. Maria Hearns Rivas. I'm an ambulatory care pharmacist with a 10-year experience. I have had the honor of caring for Spanish-speaking patients throughout the state of California, from Ukiah to San Isidro. I currently work for an integrated healthcare system in Southern California. I am also a board member at the National Hispanic Pharmacist Association, as well as an advisory group member for the Office of Binational Border Health in the California Department of Public Health.
Thank you, Maria. I'm so excited. It's clear that we're in for an exciting talk today. So our learning objective number 1 is to integrate Latine cultural values into pharmacy practice to facilitate trust, enhance shared decision-making, and improve health outcomes for Spanish-speaking patients. Secondly, we'd also like to utilize culturally responsive communication techniques in patient counseling to overcome barriers to care, such as language, documentation, insurance, improved medication health literacy when engaging with diverse Spanish-speaking populations. So those are our objectives today. And I'd really like to, Maria, start us off by setting the foundation to build the bridge. Can you help set us up here?
I'd love to set the stage for both this initiative and for this specific conversation. To introduce a quotation from American Studies PhD candidate Esperanza Santos, she shares here with us. I think her insight's very valuable. Your job as a healthcare provider is to speak your patient's linguistic and cultural language. You want to speak in a way that builds trust and gets them to listen to you. This means using terms and language that makes them feel at ease, and that might include a word such as Latinx, Hispanic, Latino, Latina, Chicano, Chicana, Latine, or something else. So it's just a few, just kind of a friendly way of approaching the patients and keeping this in mind so that we can have that bidirectional open communication with our Spanish-speaking patients.
Perfect. Thank you for expanding on that, Maria. And of course, before we can cross the bridge, we have to first build it, right? Do you want to expand a little bit on this metaphor and how it relates to time in our interactions with our Spanish-speaking patients?
Yes, so this is the foundation for effective clinical communication. As with all interactions, relationship connection must precede any cultural or therapeutic guidance. Without this foundation, the communication bridge may fail, and this may lead to medication errors, exacerbating health disparities. An example could be as simple as taking the time to pronounce the patient's name correctly, or if we mispronounce it, just asking them to correct us, or taking the time to ask about their family.
Perfect. I definitely agree. And I think a lot of people can feel heard and respected when a name is pronounced correctly. Also, in our practices, Maria, we both really value the use of motivational interviewing, right? And I think sometimes people think motivational interviewing is going to take too long. I can't possibly use motivational interviewing effectively and in a concise way. And I will say that when you're starting off with motivational interviewing, it can be kind of a bit clunky, but when you really have integrated it well into your practice and you have professional training, it can feel a lot more comfortable and it can actually be more efficient. For example, if you're talking to somebody about the foods that they're eating, And maybe in pharmacy school, you learned talk about the plate method, right? And I think we can miss the idea of what if somebody isn't even eating on a plate, for example. You've missed that detail, and you're teaching them what their plate should look like, right? But and in which case, a lot of times I will start a conversation with, what foods do you think get your sugars in trouble? And everybody can answer that question. For me, it is cookies. There are certain types of cookies that I can just eat, overindulge in, really, right? And so everybody can answer what foods get your sugars in trouble, right? So sometimes I start there, and it's more efficient. Sometimes it really does take a longer time, kind of a long game, if you will, not necessarily even just in the conciseness of the interaction, but looking as a pharmacist at, I'm walking in here, I think you should start insulin today. But I walk in there and then understand that they're really pretty apprehensive to starting insulin, and they much prefer to work on changing some of the foods that they're eating or changing their exercise activities, right? And then it you sometimes you even feel like, oh gosh, I wish you would just start insulin, right? Because you need to, and it would be much more effective. And I don't know how successful you're going to be with those changes, but but allowing or hearing the patient, that that's what their preference is, and that's what they want to try, and that's what they want to try before taking the next step to insulin, is something that we need to be open to hearing, and working with the patient's autonomy to choose that before making the decision to move to insulin, if that's the step that needs to be taken. And without taking that time to really respect that person's journey and that person's process, then we may do more harm than good, both with our safety and rapport with the patient, as well as potentially not building a relationship and safety with that person, and ultimately that person never getting insulin because maybe they never come back to see us, versus maybe waiting that 6 month window where they really just want to see how they do with their lifestyle changes that they want to make. And then potentially, if there's a struggle there, then committing to insulin after that. And that really being the journey that that person needed to take, and us respecting that journey. So, Maria, is there something that you wanted to add to that?
I mean, I could have explained it better myself. The one thing that I appreciate and I love about motivational interviewing is that it places the ownership of that next step on the patient, and there's no better expert on that patient than that particular patient. So whatever it is that they think is their next best step, I really appreciate how motivational interviewing allows them and it gives them that permission. So beautifully said, Jasmine.
That's a nice segue, Maria, into language concordance and why culturally responsive language concordant care matters, and how language can be a really important social driver of health. Do you want to expand on that, Maria?
Yes. So, one of the things to keep in mind is, and the way that I see it as a bilingual, bicultural pharmacist with Spanish speaking patients, is that, to be quite honest, a medication will only be as good as the patient understands to take it. You know, we can give them the best, most top of the line, latest, potentially most expensive medication, but if they don't know how to take it correctly, then it's almost all good for nothing. Language discordance is linked to increased medication errors, emergency visits, and hospitalizations. It also decreases medication adherence and patient satisfaction. So if we could just help the patient, go over that bridge of completely and fully understanding what it means to have that particular medical condition, and or how to, actually I should say, and how to take that medication, because as a pharmacist, we're here specifically for that. Then we can help the patient have a higher success rate, and in the long run, having improved health outcomes in that particular community.
I also want to expand on the beautiful diversity of Spanish speaking communities, Maria. I'd love to hear your perspective on this.
There are a wide variety of patients. We're all a little bit different. Yes, we all speak the same Spanish language, but we may use different words for different things or individuals. So, one of the things that I learned in speaking to my Spanish speaking patients from other countries is that it was always a very interesting and enriching experience just getting to learn from other languages. The plátano macho or a casamiento, or, it's always been very interesting and always a pleasure to talk to them and just kind of sharing our common ground and our differences and just really appreciating each other. I think that just in general, that also brought me to just all of our patients because the US is a very diverse country, just always going in with an open mind and, always willing to learn. I think it always, it's worth the time.
Wonderful. Um, Quality goes hand in hand with everything that we've been talking about up to this point as well, right? So quality safety has to be our North Star. And as many of us know, interactions that require interpreting or translating services take additional time, like we mentioned. We can and should make the commitment to taking the extra time to ensure quality and prevent health disparities day in and day out. It's just a commitment that we have to make if we are not language concordant with some patient communities, that the interpreting is going to take you a longer time, and making any necessary adjustments to accommodate that extra time is the commitment that we need to make in the space. Maria?
Yes, quality must remain our North Star. I definitely agree with that. And I agree with you all. I know that we're all thinking it. It's easier said than done. There's a lot of pressure from our employer, delivering results, outcomes, etc., metrics that we need to meet. And while all of that is true, I kindly insist that yes, it is worth the time to invest up at front at the beginning with our Spanish speaking patients, patients who have English as their second language. And the reason why I think of it as an investment is also because if we can just take that time at the very beginning to build that trust, later on down the road, when another issue comes up for that very same patient, you've already built trust and rapport with the patient. They already know that they can trust you. So that amount of time that it took to educate the patient on a particular counseling point for a medication, and maybe at the beginning they were hesitant, it'll probably be that later on down the line, they're going to readily accept the counseling points that you're providing them on their new medications because they already trust you. They know that they can rely on you. And I can say that there's been many times, and I'm sure you've had them too, Jasmine, where we didn't quite keep an eye on the clock, and the time is ticking, and we're running out of time, and our next patient is waiting for us, and we still have to document. So I will say that where there's a will, there's a way, and there are strategies to make sure that we're keeping up with the documentation. Essentially, right? If we don't document it, it didn't happen. So we need to make sure that we are also keeping that piece in mind. And so there are strategies to make sure that we are basically keeping up with the demand of our particular job. And I can also tell you all, and a vivid example that comes to mind is when I was working at a federally qualified health center in Napa. I came across a patient who had historically been his INR had historically been out of range. And every single interaction that I had with him, it was always a window of opportunity of getting to why it was that in that particular case, the INR was out of range. And in having that open dialogue, getting to know him and his wife, who would always accompany him, there was always an opportunity for enhancing what he already knew, and then how to put into perspective the things that he was doing and consuming at home were affecting his INR. So little by little, visit after visit, his INR came closer and closer to stay within the INR range goal. And then over time, he was actually able to stay within that range goal. There are ways, I would say, depending on the system that you're using for documentation. I'm pretty sure that there are ways of streamlining. I'd also say that if best resource might be to reach out to your IT specialist in the sense of that particular electronic medical record system. But anything else you'd like to add, Jasmine, to that?
Um, I don't think so. I one shortcut that I know my note template. So in our EHR, I can just use a dot phrase and a specific note template comes up. But the example and the take home message is that there are ways to ensure that your documentation. So maybe it's for someone who's using an interpreter that there's an interpreter template used that you enter in the interpreter's number or something like that that makes the documentation piece maybe a little bit more streamlined. So let's also quickly review some interpreter best practices, Maria. So we've spent a lot of time on, the time it takes and the importance of using them. So let's talk a little bit about best practices and maybe some of the challenges that people may encounter when using maybe ad hoc interpreters or even working with family members as interpreters, and when interpreters may not be enough. Can you expand on that, Maria?
Yes. So I remember being an undergrad student, and I would there's courses that can that offer like how to be a medical interpreter. I know that there's like a national certification to be able to be a medical interpreter as well. Um, Over the years and taking these like review courses and like before I became a pharmacist, it was always very, we also try to make it be very clear that it is best not to use family members to be the interpreter. Or like an ad hoc individual or front office staff member. And the reason for that is one, the information might be very sensitive, so you may not want to use the patient's, child to interpret. And then there might also be medical terminology that the, for instance, front office staff member might not know. Two, is that ideally in a more complex situation, so perhaps like in a new diagnosis situation, or going over like medications that are a little bit more complicated, having an in-person interpreter might be best. I can say that for the most part, when I'm speaking in Spanish with my patients, I do try to tune in to I try to make sure that I'm using simple layman's terms, medical words, or words that I know that are colloquial for the Spanish speaking community. And an interpreter over the phone might not be able to pick up if a patient is looking confused, or if the individual who's speaking English is using the interpreter. And if you have the patient there in front of you, also paying attention to the patient's facial expressions or cues, or if they're kind of looking down a lot and just saying yes, perhaps the English speaking provider might be able to pick up on that and then provide that information to perhaps the interpreter over the phone, although ideally, hopefully it'll be in person. But then the English speaking provider could then further ask the interpreter, hey, the patient, whatever it is that you're gauging from that body language, and asking the interpreter to perhaps ask it in a different way and perhaps describing that medical word so that the patient can then better understand it. And so it would be important to make sure that we are assessing the patient's fears. Fears can range in a wide variety. I can tell you that right now, I quite literally had a patient who was afraid in going out for a walk because of their immigration status and what that might cause, so that there's a lot of anxiety there. I know that, in using the interpreter, it can take quite a bit of time. And it's also important that when we are interacting with these patients, we also assess for if there might be a chance of like low literacy, which is why it's important to be able to, if possible, to read those body language cues so that if they're not understanding, we can explain that medical term. And then also when we are counseling patients on, for instance, like the dosage of a medication, particularly like if it's milliliters, does the patient know what that specific number of milliliters is? Do they know how to measure it? Things like that. So overall, using a professional interpreter would be ideal. In person would be the best. If not, then over the telephone. But know that if it is over the telephone, the interpreter won't be able to read that body language. So then the English speaking provider, if they can help the interpreter better gauge that.
I think the thing that I want to just is adjacent to that, and I'd really like to expand on here is I know a lot of people watching are thinking time. I don't have the time. I can't do this. It takes double the amount of time, if not triple the amount of time to do motivational interviewing with an interpreter, right? And one of the things that, when we're looking at holistic care, obviously we don't want to create health disparities. We don't want to sacrifice the care that we provide. Are there things that you can do to ensure that you're still providing optimal care by prioritizing? I need to focus on this piece. I am suggesting, though, is if you are stuck with a 30-minute, pretty strict time frame, prioritize the work that really needs to be done. And what Maria and I are saying here is the safety, the trust, and the rapport is so important that we can't let that, we can't not prioritize that. Right. And if we continue to prioritize the safety and the trust, that is just as an important intervention as potentially recommending a blood pressure medication that if you skipped the safety, the trust, and the rapport, they're not going to take anyways. so, so when we look at providing optimal care, and some of what our dissonance is in our head is, well, I have to make sure that the patient gets the right medication. I'm thinking with my ambulatory care hat on, but this can obviously relate to a lot of different pharmacy spaces. I just want us to, take a step back and make sure that we're prioritizing the safety, the trust, and the rapport, and that is as important as whatever the therapeutic change we need to make is. It's really prioritizing what really needs to get done.
If I could piggyback off a little bit,
Sure.
so a couple of things that were coming up for me as Jasmine was talking about this. Say that you are actually really building rapport with the patient. And sometimes, and you probably have come across this too, Jasmine, where patients are just sharing a lot of information. And, I've done it a couple of times where I tell the patient, you know what, I'd really love to hear that story. I have about 5 more minutes. I need to get to my next patient. How about we circle back to this at our next encounter? And they're like, oh, yes, of course. And then we can focus on the questions. Or the other thing, too, like also, as Jasmine was mentioning, thinking with my ambulatory hat, if there are some things that you didn't quite get to at this time because they were lower priority, they'll come back for follow-up. So, just a quick touch base about what it is that they need to come back to. And then in terms of what Jasmine was talking about earlier about the dot phrases, you will come to a place eventually where you are basically having very similar conversations with the patients over and over again, that you can continue to enhance your templates and your dot phrases to where it's a very quick and simple, just kind of typing up a few things and boom, it's all right there. So to basically help you speed up in the documentation process so that we don't have to sacrifice that time needed for a patient. So just a few other thoughts, Jasmine, that came to my mind as you were sharing your valuable clinical pearls here.
I think it's a really good segue into our next piece, understanding the difference between relational and transactional care. And we've touched on some of it, but is there anything else you wanted to expand on there?
I think the core piece is that if we take the time to have that relational care, yes, it's going to take time. Yes, we might run out of time for the documentation piece, but it's going to be a really good investment moving forward to keep that particular patient and community healthy. Just kind of how we had, and I think this is actually going to come up a little bit later, but the patient wants to feel connected. They want to feel like somebody cares, and they will also want to feel like we're listening. So giving them that space. Whereas if we're just making it transactional because, our queue is turning red and we have a long line of waiters, and we just need to hurry up and, get those patients out, or we're in clinic, we have our set schedule of patients, but then we also have walk-ins, how do we balance all of that? If we just take a few minutes to just build on that rapport or just listen to what the patient has to say. And then if you need to segue, I really wish we could continue this conversation. Can we continue at our next follow-up appointment? I'd love to hear more. Usually, most of the time when I've had to use that to kind of gently transition the patient to let's wrap it up, etc. Usually they're very receptive to it, they're welcoming, and they're already looking forward to coming back and talking to their provider.
And so I really like the tip that you shared of just like I'd really like to hear all the things that you have to say. Maria, there was an interesting qualitative study of 14 clinicians in Southern California, right? And talking about basically interpreter choices and medication safety. Do you want to expand a little bit on that?
In this particular study, they did also notice that the clinicians strongly preferred in-person or video interpreters over telephone only, kind of alluding to, some of the challenges that we were talking about. As they mentioned, citing loss of nonverbal cues, audio programs, and patient frustrations, how we mentioned. Some of the practice implications that they're recommending from this particular study is to aim to improve 24/7 access to trained interpreters, especially in person and video, ensure translated medication materials. It's helpful to be able to do that counseling session with the patient, but it's also, I would say, even more helpful to have them go home with those particular pieces of handouts so they can have something to refer to when they go home. And then also they're recommending to address reimbursement to interpreter use and its sustainability. So, it's nice to have a recommendation, but then we also need to be able to sustain it in some way. So I thought it was a very, very interesting study. I think that they are shedding a lot of light on some of the current real world frustrations that we're having. And so, we hope that this can further help enhance and inform other pharmacists in their pharmacy setting.
Particularly in this foundational program, I think it's helpful for us to review the meaning of personalismo, familismo, and respeto, and why it matters when taking care of these patients and Spanish speaking patients. A couple of my examples in terms of familismo, I just recently had kind of a young couple. The the male was newly diagnosed and had his girlfriend or spouse there, and it was so clear that they were just looking at each other and saying, like, he would not make a decision without her. He needed, well, what do you think I should do? And I think this happens in a lot of cultures, but it's my most recent example of with some of my Spanish speaking patients that it was this bond, it was this closeness, it was this affection, it was everything. I believe we were talking about him starting insulin and he was kind of scared and she was being encouraging. And I was not that instrumental in the conversation. It was more that they were making that decision together. I do think that we see that sort of just relationship building as really prioritized and important, particularly with our Spanish speaking clients, patients who really value this closeness or the relationship building. Maria, do you have any examples that you wanted to share?
Yeah, so the very first example that comes to mind, and I will admit that this is likely the foundation to all of my other interactions, but it's with my grandmother. She lived with us, she raised us, and so there was a lot of, respeto. I mean, we called our grandmother usted. It wasn't tú. And so that was like number one, usted. And so even as I would have even Spanish speaking students, just reminding them like we are not on a at a first name basis here with our patients. It's usted. Even to this day, even if my patient is younger than me, it's still usted, because there is that sort of respeto, that formality, and I think that formality really helps us start to bridge that gap, to build that rapport, because it doesn't matter what they do or where they come from, but we're here to support them and help them and serve them. And then the other part, in terms of personalismo, in the sense of building the connection, doing the small talk, etc. So I was thinking, and I'm like, okay, so if I was in a rush, which usually I was, and how do I help others build this personalismo? And it starts with a smile and a greeting, and at least pre-COVID, depending on how people are feeling now, but walking up to the waiting area and asking for their name and shaking their hand and walking them over. And even in that time when you're getting the patient from the waiting area and walking them over to the patient room, or if they're walking in through that door in the patient room, or they're standing right in front of you in that pharmacy counter, just taking the time to pause and smile and just saying their name, or at least trying to, and asking them to correct you. I think that smile can really go very long ways. But definitely, personalismo, familismo, and respeto, it can take us very far. And I can tell you that I've also heard complaints from patients about how they had been dissatisfied when a provider did not show them respect, when they did not allow them to give them that space to consult with their family, when somebody was really cold and rushed and just kind of going through the motions and just trying to, get everything done, and that not having that connection, patients feel it. They may not express it right away, but they might not come back.
Thanks, Maria. As we kind of are coming up on the end of our session today, I want to do a quick role play, to really emphasize the importance of teach back. So, Maria, if you'll humor me here for a second, and I think I can play the role of the pharmacist. Let's do an ambulatory care setting because that's where you and I are probably most at home. So you know the role of the patient very well, and I will be the provider. And let's just kind of set the scene as maybe this is you were fairly recently diagnosed and this is a new metformin start, and we'll kind of just go from there just to give the audience a little bit of a sample of a little bit of motivational interviewing, the importance of the teach back method and how that may look particularly in some Latino cultures. So let's jump into it, Maria, if you're good with that.
Yes. Yes,
Okay. Um, we're going to do it in English. I should add. I almost started speaking Spanish. So, Maria, hi, how are you doing today? I saw that you were just recently diagnosed with diabetes, and I know that that can be difficult. I just wanted to talk to you today a little bit about that.
Yes, my provider, my doctor, my physician, she told me that my labs came back high, and she told me that I have diabetes and that I should come to you because I'm supposed to start some sort of medication. My family's in disbelief, but at the same time, my parents have it, my sister has it, grandparents have it, so they're not entirely surprised, but there's a sum of disbelief so far.
Yeah, yeah. It runs a lot in my family too, Maria. So you kind of know it's coming down the line sometimes. Can you tell me a little bit about kind of what you know about diabetes and how you're feeling about starting any new medicines?
Yeah, so I'm not very convinced that I need it. Yes, I have heard of metformin. I have seen it. My grandmother was taking it for some time. And the reason why I'm concerned with it is because when she started taking it, they actually ended up taking her off of it, and she ended up on dialysis. So I don't want to end up on dialysis like my grandmother.
Yeah, it sounds like there's a lot that's going on in your mind about, starting metformin therapy in specifically in that medicine. Um, do you have any questions about metformin, or it sounds like you have some fears there because your grandmother had a specific experience with it, but are there any fears that you have specifically about potentially starting this medicine?
Yeah, I'm concerned that it's going to damage my kidneys.
Okay. And Maria, that's a common concern. And do you mind if I share with you some of what the relationship is with metformin and diabetes and the kidneys?
Yes, please.
Yeah, so I think a lot of times people hear metformin and kidneys and they don't know really kind of what that relationship is. And what we do know, what we're confident about is when your sugars are high and when your sugars are high for a long time, that damages your kidneys. We are 100% certain that that is a complication that arises from high sugars for a long time. A lot of people with diabetes take the medicine metformin, right? And what happens when your kidneys aren't working very well, metformin can actually build up. And that's when there are problems. When your kidneys are not working well because of the damage and the problems from the high sugars, then metformin can build up and cause problems. Usually what we see though is if your sugars are at a healthy level, and metformin is one of the medicines that can help do that, then you can you can prevent that kidney damage from happening. And that's really what the conversation is about today, Maria, is how do we prevent your sugars from doing much more damage to your eyes, your kidneys, and the nerves in your feet and in your legs. And what we know is that the longer that your sugars stay high, that is when your risk for those problems really is higher. And so that's more the relationship of metformin, diabetes, and the kidney. And really what we're looking to do is get your sugars to a healthy level to prevent problems with your kidneys and keep you safely on metformin. Does that make sense? Or tell me kind of
Yeah.
what you're thinking now.
Well, I don't want to end up in dialysis like my grandmother. And if it was her uncontrolled sugars that caused her to do that, I don't want to go down that pathway. So, if metformin will keep my sugars controlled and help me prevent that, then I think that's the way that I want to go.
Okay, Maria, the other thing is you can start metformin if you feel uncomfortable with it, if you don't tolerate it well. We know that oftentimes when you start the medicine, you may have some diarrhea, and that can be pretty severe up front. I just want to let you know to expect that so that it's not something that scares you. We do see that as a side effect. Oftentimes, we hope that it gets better after the first couple of weeks. We're going to start you on the lowest dose so that you have the best chance at tolerating that. But this isn't a sentence, right? So there are other therapies that we can try if you really don't tolerate the metformin well. This is something that you can try, see if you like it, see if you like the changes that you see with your sugars. Oftentimes, people do have to be on this medication long term if they tolerate it well and if they see it's working for them. So I just want to make sure that you're comfortable with all of that information before making the decision to start taking metformin. Is that helpful, or do you have other questions?
No, this is helpful to know, and I really need to stay healthy because I'm the primary breadwinner for my family, and my parents and grandparents depend on me. So I really don't have a choice. I really do need to stay healthy for them.
Right. And I know sometimes being so busy with so many responsibilities and taking care of so many other people, you can lose sight of taking care of yourself. And it sounds like you're making the decision to move forward with the metformin and take care of your sugars so that you can continue to take care of your family. And that's a wonderful decision in taking care of yourself. And I am here to answer any of your questions. We can make modifications in the future if we need to, but I'm here for that, for any questions that you may have.
Thank you, Dr. Gonzalez.
And scene. Right? You were actually not that stubborn of a patient, right? And maybe sometimes we do see a little bit more pushback with that, but this was just an example of how motivational interviewing, reflective listening, asking for permission to share information, make any provide additional information to allay any misconceptions. This was just sort of a brief example that we wanted to share with motivational interviewing. I forgot to do the teach back. So if we go back into the role play, Maria, I might end up saying something along the lines of, so starting the low dose of metformin, 500 milligrams once daily. Usually you take that with food so that it doesn't upset your stomach quite as much. Would you mind kind of repeating those instructions back to me just so I make sure we're on the same page?
Yes, so it's going to be metformin, 500 milligrams, and I'll be taking one tablet with food specifically, so not without, but with food, to hopefully help decrease that possibility of diarrhea, I believe.
Yeah, yep, you got it. And again, I'm here for your questions, but yes, I think you repeated that and you seem to understand exactly how you're supposed to take it.
Thank you.
So that piece, that teach back can be critically important, particularly when you're working with interpreters and you're making sure that the right message has been interpreted if the patient is able to say that with their own words. So thank you, Maria, for walking through that role play with me. I think one of the last things that we want to end on here, one of these ideas, is this idea of transcreation and transcreation, transforming communication and care. Can you expand a little bit about that? Do you have a quote that you like to highlight that idea?
So this was adapted from Napoles and Stewart, 2018. And they say here that transcreation is the process of culturally and linguistically shaping evidence-based interventions with the community so they resonate in meaning, relevance, and real-world applicability, not simply translating words, but transforming the message. And what comes to mind when it comes to transcreation, one is when translating documents, it's not just a literal word for word because syntax can be opposites in English and in Spanish, so we have to keep that one piece in mind. But then also the meaning, like it's pouring cats and dogs. We're not going to say está lloviendo perros y gatos. We're going to say está lloviendo a cántaros, right? So we have to be able to keep in mind that cultural and colloquial context for each of these communities. And then I was trying really hard to think of where have I seen this transcreation in the sense of we're taking a recommendation from a health condition association and what they found that really works for communities, and then how do we adapt that to the community to make it their own and to really see progress in that community. So the one example, and I'm sure you have others too, Jasmine, that comes to mind is when I was working at the Federally Qualified Health Center, they had a diabetes support group. So this was modeled after the Diabetes Self-Management Education and Support Program. And what I thought was really interesting is that, number one, it was in Spanish. Number two, it was at the times that they needed it to be. So a lot of them are working individuals. They don't have the luxury of taking earned time off or PTO off, So it was when they were available and usually in the evenings. And then also that they if they could have a one-stop shop for everything, that was the most ideal. So, it was the diabetes group session going on con las señoras. And they would very sweetly joke around with each other, ¿cómo estás? And stuff like that. And, oh, muy azucaradita, like, oh, my sugars are a little high, or just my little sugars are high. Anyways, terms of endearment. And then we would also have somebody checking blood pressures and somebody providing refills and just kind of putting the patient really at the center of what they need within the constrictions of their lifestyle. So I couldn't think of a better example than that. I don't know if you have any other examples, Jasmine.
I think honestly, just bringing it to a lot of the content that we focused on today, that motivational interviewing really is sort of like transcreation, that we are doing something together and that we are listening to the patient like from the community, and that so just bringing it down to sort of that one-on-one level of transcreation can even be on that patient level, and then expanded to the community level. So that's all. So much of what we are saying today, I hope, is resonating as sort of a cohesive message. And with that, I would love to just kind of end on our Smarty goals for you. So specific, measurable, attainable, relevant, timely, inclusive, and equitable Smarty goals. Would love for you all to walk away with an example goal. For example, over the next 4 weeks, allocate an extra 2 to 3 minutes during initiation of new chronic medications for 5 Spanish-speaking patients using teach back method to confirm understanding. If you haven't been in the habit of doing that. We put some examples of Smarty goals on here just so that you walk away with some action items as a result of listening to this presentation today. So we hope that you have had a nice time listening to our conversation here, that you took away some tangible examples to take back to your places of employment, your patient care spaces. We encourage you to please see the wide range of resources on the CME Outfitters website. The CMEO Health Access and Social Responsibility Hub also has more resources to help increase your skills in fostering a welcoming, fair, and inclusive environment. This program is part of a broader initiative focused on helping pharmacists and pharmacy technicians enhance culturally sensitive communication with Spanish-speaking patients, and I'll be moderating other programs in this series. To receive credit for this activity, please complete the post-test and evaluation. We appreciate your feedback. I want to sincerely thank you, our audience, and Maria for your time today. We appreciate your participating so we all can provide the best care for our patients. Maria, did you want to add anything else?
It was a pleasure. I had a lot of fun. I hope that we were able to share some valuable tips to our audience.